So thank you very much for inviting me to join you this afternoon. It's a great pleasure. I've just worked out that it's 25 years since I left Hong Kong, but obviously have had many pleasurable trips back since then, although sadly not on this occasion. But it is lovely to be able to join you anyway from England. Obviously, because all this time I've been here, my experience in terms of policy is going to be very much from an English context. But I hope that what I can share with you today is something that can be used wherever you are. So let me start by saying, just to remind us, first of all, of the challenges that we have. And even though the challenges are familiar to me in England, I think they're familiar to everybody all around the world. We all have an aging population. We all have more and more people, because of increasing multimorbidity, we have more people who need palliative and end-of-life care over the next while, over the next few decades at the very least. At the other end, we also have children with life-limiting illnesses now living longer and requiring palliative care and living into adulthood. Something that we certainly struggle with in the UK, and I suspect in many parts of the world, is that there is a widening inequity, for example, between socioeconomic class, which I'll come to in a minute, and between different population groups. So some people are able to receive very good healthcare, very good palliative care, and other people are less visible to the system. Of course, at the same time as having an aging population, we also have an aging workforce, and certainly in the UK, a diminishing workforce, which we're desperately trying to recruit to. The narrative can be difficult, and again, this is slightly language dependent, but it is difficult to get the terminology right. So one of the, I think, problems we had in the UK was that back in 2008, a new terminology of end-of-life care, which in the UK context means the last 12 months of life, was introduced. Now, many people will think of end of life as being the very last weeks of life. And so that causes a particular confusion, which can be difficult to explain. There is also a public and political shyness, I think, about death and dying, about talking about death and dying, and about confronting the fact that death and dying is happening. And even during this pandemic, when you cannot avoid recognizing that people die, there is still a shyness away from it. And of course, resources are never enough for palliative and end-of-life care. I mentioned earlier on about the widening inequity, and you can see this is actually a study that was done in Scotland using GP practices. It's quite a famous study and about 8 years old now, so I expect many of you will know about it. But if you look at it, for example, if you're kind of in the 55 to 59 age bracket, there is really almost a sort of a doubling chance of you having multi-morbidity at the same age, depending on whether you are in the best socioeconomic class, which is down here, to the worst socioeconomic class up here. So your chances of having multiple conditions and therefore requiring, having multiple health problems and therefore requiring a lot more both disease-specific treatment, but also palliative care becomes greater. So those are the inequities that we have to deal with, which is not just sitting with palliative and end-of-life care, but is actually really important. So let me turn to my subject of transforming policy to practice. I think between policy and getting to practice, we need to think about the process and procedures that moves us from policy into practice. But policy and practice do not sit in isolation. Now, many of you will have heard of something called the VUCA, which stands for volatility, uncertainty, complexity, and ambiguity. And what's behind that is to say, look, you know, that's the environment. And therefore we have to take, if you're doing any kind of thinking at all about policy, about practice, about system change, you've got to think about VUCA. I've changed VUCA into these terms here because I just find that more helpful and more useful. So let me take you through it. So policy, processes, procedures, and practice all sit within this environment. It is a complex environment because things are changing all the time and things are different. So for example, what is happening in the housing area, for example, and the economics of the country and is interacting with healthcare all the time. And we cannot look at healthcare in isolation. We know that there are always constraints. There's always more we can do. There's always limits to what we can do. There's always limits to what can be achieved. And therefore, we have to find ways around these constraints. Similarly, the environment is constantly changing. So you cannot write policy expecting that all of these things will stay the same. And you cannot write policy in isolation. On the other hand, the more connected you can be, and I will explain that a little bit more in a minute, but the more policies can be aligned and connected, then the greater the success of translating that into practice. The clearer the policy, the easier it is for people to understand what needs to be done and to be able to develop processes and procedures that actually make practice a reality. And then I've added this, which has got nothing to do with VUCA at all, which is what I've called conscience-driven, because I think at the end of the day, policies have got to be about doing the right thing. And it's got to be about doing the right thing for the most people as best we can. And unless it's conscience-driven, then policy feels really hollow. So I think it's really important that we think of the context in which we develop policy and think about how we make sure that policies are the right things to do. And we won't always get it right, of course. We have to keep thinking about it, and we've got to keep evaluating it, which I will come to in a minute. Michael Hammer was an engineer who was very much specializing in process re-engineering, and he died about 12 years ago. And he said, the secret of success is not to foresee the future. It is to build a system that is able to prosper in any of the unforeseeable futures. And I thought that was really a rather good way of summarizing how we should think about developing policy. So as I said, we've got policy to procedures to practice. And of course, procedures, practice, and is all about implementation, which I will come to towards the end of my talk. But we also have to think about evaluation, because it would be very dangerous to go from policy to practice without thinking about the evaluation and without revisiting and rethinking about policy. But before we get to all of that, we need to start by thinking about the policy itself, because it's really easy to sit in a room and write a policy, or to maybe get together with a few people and write a policy. But actually, if the policy is really of high quality and does all those things that I talked about being connected and clear and conscience-driven, then the greater success, the greater the chance of success of that policy, and the greater the chance that it does what you want it to do. So let me spend a little bit of time thinking about how we develop policy, or what's needed rather to develop policy. So I think the first thing is we need to understand the context. So what is the right policy that we're developing here in the UK is not necessarily the right context for you in Hong Kong. Your context is very different. Our recent context, our recent history, our political situation, all of those things obviously influence the context. But so does our healthcare system and our demographics, our population, our the model of healthcare, etc. I will come back to some of those later on. So understanding the context in which we're developing policy is really, really important. It's also important to learn from the past. It's so easy to just simply think about, this is what we should achieve, this is what we should do, and not learn the lessons of the past. There's very rarely policy that is totally new. It is things that we have evolved from. And if we don't learn from the past, then we simply repeat the mistakes of the past. Right from the beginning, if we can engage our stakeholders, the wider stakeholders, the people who will actually either benefit from or suffer from the policies need to be engaged from the beginning, because then that way you can make sure that it is more connected to their needs and to the impact. And that means having diverse perspectives, having different people. It is very comforting when one is kind of writing, developing policy to have people who agree with you, but that's actually really unhelpful in the longer term. So you need people who are going to question and challenge and check on what you're doing. And then as you develop the policy, as it takes form, you shape it, you test it. There is no need to launch a policy, even though that's tempting, just all of its own. You want to test it. And you want to kind of ask the question of, is it what it seems? So on the right here, I've got a picture. I don't know whether any of you have seen this before, but this is the double helix staircase in the Chateau de Chambo, which is in the Loire Valley in France. Now, on the face of it, it looks like a rather lovely Renaissance staircase. In fact, it is a double helix, so you can actually go up the staircase without ever meeting somebody who's coming down the staircase. It's actually a double staircase. So, you know, whatever policy you're developing, is it what it seems? Does it have unintended consequences? So one example is one that was in the UK. So this is quite a famous piece of work, which was looking at the cost of care at the end of life. Now, if you look at it, what it shows here is the average hospital cost goes up really exponentially in the last 90 days of life. And that would tempt people to develop policies that says that actually we should do everything we can not to admit people to hospital if they're likely to be in their last 3 months of life. But if you look closely at the figures, you will see that actually the non-emergency inpatient care really doesn't increase at all during those 3 months. If anything, it diminishes towards the end. The real cost is in the emergency admissions in the last 90 days of life. And of course, emergency admissions are not great experiences for patients either. So not only is there a cost, but it's actually a cost to the patients and to their families. So therefore, that policy, instead of saying, actually, we should be trying to find ways to keep people out of hospital in the last 3 months of life, we should be looking to say, how do we manage emergency situations when they crop up in the last 3 months of life? Is our response the right thing to do? Have we done enough anticipatory care? Have we done enough planning? And when unexpected things happen, as they always will, have we got the right responses and services in place for it? So this is where examining the data and looking for unintended consequences is really, really important. And then finally, when you've kind of developed the policy, you need to turn it upside down, look at it from the side, look at it from all angles, and kind of say, actually, you know what, is this what we want to go ahead with? So that's really kind of what I mean about trying to develop a policy that is as good as you can have it. Of course, it won't be perfect. No policy is ever perfect. But at least if you start off reasonably, you've got a reasonable chance of being able to move forward. Now, I said at the beginning that we have to understand the context. So no policy arrives in isolation, and no policy doesn't come with a history of some kind. So I'm now going to spend a bit of time talking about an example in England. So this is the policy context in England for palliative and end-of-life care. So in 2008, there was a national strategy, which was the first national strategy for end-of-life care. That was when that term, end-of-life care, was phrased, and the working definition of the last 12 months of life was phrased. So from now on, when I talk about end-of-life care, I am generally talking about that last year of life. Then what happened in England was that in 2013, there was an independent review of the livable care pathway, and this report called More Care, Less Pathway was published, followed by a response to that report called One Chance to Get It Right, and that was published in 2014. So these were very important context for the ambitions for palliative and end-of-life care framework, which is really the main policy I'm going to be talking about. But because this was just the palliative care context, there was also a national context, which was that in 2013, the law changed for healthcare. The Health and Social Care Act came into force, and that meant that organizations like mine, which is NHS England, then became an arm's length body. And that developed a 5-year forward view. So anything we do on this side, anything we do on this side needs to actually take that national context into account. So I've already talked about the 2008 strategy, the livable care pathway and the response to that. And then there were many, many other reports because of the 2008 strategy. When we moved into NHS England in 2013, there was a whole lot of legacy actions that needed to be picked up as well. And then there were various other reports, including a parliamentary inquiry into end-of-life care and an ombudsman inquiry into end-of-life care. So in thinking about developing a policy that is national, that will hold everybody together, that will do all the things I talked about in terms of engaging stakeholders, we needed to take all of that into account. So the first thing we did was to gather together a set of partners. Now there were 27 partners on this slide. There were 27 partners who came together with us to develop this policy. And they range from regulators, such as our Care Quality Commission, to our Royal Colleges of the Physicians, of Nurses, and of General Practice, the Association for Palliative Medicine, the ambulance services, and then the charities like Marie Curie and Macmillan. They were all involved in that. But also there were the umbrella organizations like Hospice UK, National Council for Palliative Care, the specialist societies around nurse consultants, around healthcare chaplains, around social workers. So you can see that actually this had a very big range of organizations, all with different agendas, all with different voices. And that was what made it very rich in terms of developing policy. It does mean that it takes longer. It took us about a year to get from kind of bringing the group together to publishing the framework itself. The framework is now 5 years old. We're just about to refresh it. We've done a review of it. And actually what we're hearing is from all our colleagues is please don't change it. We are putting this policy into practice and we actually want to stay with it. So that's been a really powerful, I think, indicator of how it's been owned by everybody because they've been part of developing it. The first thing we had to do was actually to develop a common goal. So we had to agree a set of wordings that we could all sign up to and that our various organizations with its different agendas could sign up to. And this was the overarching vision that we were all, we all stood behind. It's not perfect from everybody's individual perspective, but it was perfect for us as a group. And so together, we published the Ambitions for Palliative and End-of-Life Care, which, as it says, is a national framework for local action. And what it does is that it sets an aspirational benchmark against which inequalities in provision can be monitored and tackled. But it was deliberately not one which sets out measurement in terms of, you know, you've got to reduce X% and that sort of thing. It was very much around, this is what we want to get to. This is what we're looking for. This is what our ambition is. How are you going to get there locally? So just a little bit, some of you will have heard me talk about the ambitions framework previously, so apologies if I'm repeating myself, but for those who haven't, the ambitions framework had 6 very simple ambitions to achieve that vision that's on the right there. And the 6 ambitions were really stated as very simple statements, and they were outcomes statements. So this is about things being achieved in order to achieve person-centered care, in order to achieve equity, in order to achieve comfort and well-being. Care being coordinated had to be separate because so many people are involved when somebody is in the last year of life that actually care is often fragmented, and it's one of the feedback that we get from patients and families about how difficult it is when the care isn't coordinated. So then all staff are prepared to care, because you can do all these for patients and for their families and for their carers. But unless you prepare staff and unless you look after them and their resilience and their support, as well as their skills, then you can't achieve any of this. And finally, the last ambition was to recognize that palliative care, death and dying, is not just a healthcare matter or even a health and social care matter. It is one for society to tackle. And therefore, each community must be prepared to help. Now, my next slide is actually a very busy one, but I'll just put it together because then you can see how it kind of comes together. Essentially, you won't be able to read the detail of it, but please don't worry. Each of those 6 ambitions, underneath each ambition, we have an I statement. So it's actually trying to look at what that ambition means for the person that we are serving. So that's the I statement there. I'll show you the first ambition in more detail in a minute. And then under each ambition, we had a set of what we call building blocks. Again, they're not comprehensive, but we hope that they're sufficient for local systems to build on and develop the actions that will help them to achieve this ambition. But we also recognize that there were a number of foundations which were cross-cutting themes, really, and they're the foundations in order to achieve those 6 ambitions. And as you can see, they include things like education and training, leadership, co-design, involving, supporting, and caring for those important to the dying person, and evidence and information. So those are foundations to achieving these 6 ambitions. Just one example. So this is the one about the first ambition, which is actually about each person being seen as an individual. So in order to achieve this ambition, we want the people we serve to be able to say, I and the people important to me have opportunities to have honest, informed, and timely conversations, and to know that I might die soon. I'm asked what matters most to me. Those who care for me know that and work with me to do what's possible. It seems a really simple statement, but if you unpack that, there's a lot to do as healthcare providers and policymakers in order to make that possible for everybody. So that's the important thing about the ambitions, is trying to make this possible for everybody, not just for a few people. Underneath the ambition is the set of building blocks, as we said. So one of them, for example, is about honest conversations. So if you take it from policy into practice, then at the practice level, you need to think about, well, how do I make this happen? How do I make it possible for people to feel that they can have honest conversations? How do I make it possible for my staff, for my colleagues to be able to have those honest conversations? What are the skills that's needed? What's the environment that's needed? And how do I encourage that to happen? So not just in terms of what you do, not just in terms of behaviors, but what is the attitude of the managers, for example? How do they encourage that? How do they allow that to happen? And so on. So I won't go through all of the blocks, but that's really what we mean by going from policy into practice. However, one of the things about policies is that I've said they never happen in isolation. They never happen without a context, but also, so they never happen without history, but they also never happen without things happening after you've published the policy. So one of the things that happened for us was that although we had, as 27 organizations, come together to work on and publish the ambitions for palliative and end-of-life care, really around the same time, our Department of Health, our Ministry of Health, decided that because there was a bigger national policy called No Decision About Me Without Me, our Ministry of Health wanted to publish something that was about end-of-life care, and it was about choice. So originally, the ministry wanted to think about choice in terms of choice of place of death. And they wanted to frame a commitment from the government that you could die at home if that's, you know, that everybody could die at home. Fortunately, we were able to persuade them that actually that was not the most important thing to everybody, and there were a lot of other more important things, and also that it would be helpful if it supported this policy rather than be completely separate and something quite different. So in effect, the government's commitment was a 6-point commitment. And in case you can't see it because it's quite small on the screen, it says the commitment is that as you approach the end of your life, you should be given the opportunity and support to have honest conversations about needs and preferences, to make informed choices about your care, supported by clear and accessible information, to develop and document a personalized care plan, to share that plan with care professionals, to involve to the extent that you wish your family, carers, and those important to you, and know who to contact if you need help and advice at any time. So we then framed that as being a way of enhancing ambition 1, which is each person is an individual, and ambition 4, which is care is coordinated. And that allowed us to actually help our colleagues who are trying to develop practice to see that actually these two policies are not conflicting. They actually build on each other. So that's really important. The other thing that I want to come back to this slide and just remind you about, having policy that is connected, that is clear, and that's conscience driven means that what it does, it gives you a platform for other things to happen. And one of the things that happened was that a different set of colleagues who worked for healthcare in prisons then took the framework, the national framework, and developed what they call the Dying Well in Custody Charter. And that charter takes those six ambitions, and under each ambition, they have set up a set of standards that prisons need to put in place in order for people who are dying in prisons to get the same kind of quality palliative care as anybody else. And then they have developed a self-assessment tool against that, so that each prison can actually measure themselves against that and do quality improvements locally, internally, in order to achieve that. So this is where you can see, a policy that is, in a sense, quite general, can then be taken and applied into very specific groups. And similarly, we commissioned these organizations to help us look at how can this be possible for other groups, like people who are homeless, the LGBT population, and gypsies and travelers. This report is particularly about that. We also have a separate one that's about learning disability, again, looking at what would the ambitions framework and those 6 ambitions look like? How do we make it possible for people with learning disability? So a sound policy can provide you with a very good platform for translating into different areas of practice. However, it is really important, any policy, and you can tell we're very proud of that policy, but any policy needs evaluating, and it needs to be constantly reviewed and thought about and kept on track, because it is very easy for things to go off track. We were very lucky in terms of evaluation, in that although we didn't specifically commission an evaluation, quite around the last few years, a colleague called Rhiannon Barker has been doing her PhD looking at policy into practice. So looking at how effective national policy is in terms of practice. She wasn't just looking at ours, but her PhD was particularly looking at national policies and doing a range of interviews with different stakeholders. And then she did 3 case studies in 3 English clinical commissioning groups to look at how policy how effective policy was. This is a slide from her paper, and the reference is down there. And her study really came up with looking at the system level factors that affect the delivery of end-of-life care. So she describes a micro level where there's individual variations in behaviors, preferences, beliefs, in the way people communicate, in the way people understand language, in their circumstances, and the motivation. And that's individual, both in terms of patients, but also in terms of professionals. At the meso level, There's some that she looked at things like the commissioning structures, the models of care, what kind of priorities there were in education and training locally. For me, the interest in terms of this lecture was around the macro level, where she looked at policy and strategy. So the first thing was the fact that actually policy did exist, even though it's fair to say that the ambitions framework, as it were, you might or might not call it a formal policy, but it's been adopted as a policy by the stakeholders. And the existence of this policy meant that people could build on it. Does it have leverage? Not really, because it's not a mandatory policy. So our ambitions framework success has been based on the stakeholders owning it, and people really believing it, and it having resonance with people, rather than actually being a government policy that says you must do X. So that's where, if we had a bit of that, that might be helpful. She also looked at things like the models of population health, and in our case, it's really a bit skewed towards secondary care at the moment, towards acute care. Looking at the structure of the health service, we're very lucky in England because we have a national health service, but the economic environment and the workforce pressures all obviously have an effect on how effective any policy can be. And I've already talked about the population. So I think her conclusion from her study was the fact that actually the ambitions framework did provide was a good policy in terms of enabling a lot of good things to happen, but there were also areas of weaknesses which came from things like the structure that we were in, the context that we were in, and we need to understand that. It's not that we can do something about that always, but if we understand that and we acknowledge it, then we can adjust our practice accordingly. So that brings me to implementation, and how does that work in that context that I've just talked about? So when I talked about, if I give a little bit of detail then about some of the constraints, for example, as a result of the Health and Social Care Act, palliative care is commissioned locally. So there are about 200 clinical commissioning groups. The country is divided into about 200 clinical commissioning groups. Those groups have been asked to work together to form integrated care systems, and the ambition is to turn that into 44 integrated systems. But the CCGs, the clinical commissioning groups, hold the legal responsibility to commission certain services, including palliative care, which means that from one CCG to the next, even if they're next to each other, they may have very different priorities, they may have very different resources, they may have a different view of the extent to which they should commission palliative care. So you may have a CCG that commissions a very integrated system of palliative care, a very joined up system where the person is absolutely in the center of it and all the services are there to wrap around the patient. The neighboring CCG may actually have other priorities on their mind, and therefore they're quite content to let palliative care carry on, as it were, to commission different services, providing different things, and leave it up to you how you join up care. So you can see that the context means that if you're a professional practicing in each of those two CCGs, it is very different how you work, and you've got to try and work with the system. So this is where the implementation piece comes in, and this is where it's really important. I'm going to share, there are many, many approaches to implementation, and I am not by any means saying that this is one way to do it, but this is quite a useful illustration, I think, and quite a useful example of how you can approach this whole question of how do you implement policy, and in effect, how do you implement change? And this is the change model, and NHS England has published this change model guide, which you should be able to get just on the website if you put into Google looking for this. But it's quite, I think it's quite intuitive. So the first thing is you need the shared purpose that holds, oops. So you need the shared purpose that holds everything together. Because if you don't have that shared purpose, then you can go off at tangents. So I explained to you with the ambitions framework how having a joint vision was so important to us, because every time, like any groups, you do your forming, you do your storming. There will be times when we will have very different agendas and we will have very different views, but always that shared purpose was what brought us back together. So unless you articulate, you work on it to start with, you articulate it, you agree to it, and you hang on to it, because that is what holds all the pieces together. Now I'm going to start at this end, because the example I'm going to use is actually the CQC. So system drivers. So what are the things that drives the system that we're trying to change? So one is obviously having the ambitions framework. Another piece before that was actually the One Chance to Get It Right, which focused particularly on care at the very end of life. So in the last days of life, okay? Whereas the ambitions framework was broader than that. It was really encompassing palliative and end of life care in its broader aspect. But those were two important system drivers, a system and policies. But the other system driver there was that the Care Quality Commission, which is the healthcare regulator, then decided that within, and they did two very important pieces of work. One was that they did a piece of work that looked at inequalities across systems and published quite a hard-hitting report around that. Although that doesn't have any leverage behind it, the fact that it's published by the healthcare regulator means that quite a lot of local systems have been able to use it to drive changes locally. The other piece of national change was that CQC, this Care Quality Commission, the health regulator, decided that they would, when they do their inspection of hospitals, and that's acute hospitals and community hospitals, not only would they do an overall inspection, they would specifically inspect for the quality of end-of-life care, for the standard of end-of-life care. And it was one of 8 specific themes that they looked at. And in every hospital they inspect, they look at end-of-life care, and they gave a specific rating for end-of-life care. And the ratings were either you could be good, you could be outstanding. On the other hand, you could be rated as requiring improvement, or at the bottom end of the scale, you could be rated as inadequate. And everybody responds to a competition. So when CQC ratings come out, organizations become very interested in improving their scores. And then we went in behind that, and this was my sister organization, NHS Improvement, and myself and my nursing lead. We went in there behind the CQC ratings. So we went to hospitals that were rated as either requires improvement or inadequate to offer our support for them to drive forward improvements that would help them to get a better score next time. And between 2016 to 2019, in 2016, there were 81 trusts that were rated as requires improvement, and that had come down to 36 by 2019. And then in 2016, there were 11 trusts that were rated as inadequate, and that's now down to 1 trust. So you can see that actually those ratings help to drive improvements. And by the way, 19 trusts went from outstanding in 2016 to 27 trusts by 2019. And there is a really great appetite now amongst those who've been rated as good to get to outstanding. And we've been working on a guide to getting to outstanding last year. It had to be paused a little bit because of the pandemic. And of course, there's no inspections going on at the moment, except on safety reasons. And therefore, those scores that I've just talked about at the end of 2019 are kind of a bit stuck until we can start moving on ahead again. But you can see that a system driver like the Care Quality Commission enables us, and they provide the measurement because they provide those scores, enables us to actually move in and work with the local team and to support them in thinking about how do they do quality improvement and manage those projects and spread it across the whole of the trust. So even within one hospital level, you can see how this change model can work. And then, of course, it's really important to motivate and mobilize. And ideally to motivate from a positive perspective rather than to motivate because you've got poor scores. So that was really important, that we were very careful when we went in to say, although the reason we're offering our help is because of your CQC rating, it's really important that you're not just trying to pass the exam. It's really important that you actually stand back and kind of say, how do we improve things, not just to get better scores, but so that our patients can get better care. So that's a really important piece, that we don't drive the wrong behaviors. And I'm going to come back to leadership by all in a minute. But underpinning the change model are three, I think, very important principles that helps you understand how you drive that change. So the first principle is understanding that everybody, we all, have intrinsic motivations and extrinsic motivations, and it's actually a combination of the two that we need in order to drive that motivation. So intrinsic motivations might be around things like, you know, this is really meaningful to me. This is what I'm passionate about. This is what gives me that sense of purpose and sense of self-worth. So that's a really important part of what drives me in my work. On the other hand, also actually having deadlines helps to drive work too. So you can see that example of CQC coming in to inspect hospitals. Actually, that is an important extrinsic goal, that, and because CQC will be coming back to re-inspect, that sets a certain deadline. But actually, if that was all it was, I know that those goals would never have improved. It was because individuals and organizations also had that intrinsic motivation. So it's the combination of those two that's really important, the balance of those two that's really important. The second principle that the change model talks about is the need for energy for change. And they talk about it in terms of 5 domains of energy for change. And energy for change is the capacity and the drive of a team or organization or system to act and make a difference, to implement policy into practice. And if you look at those domains for change, the physical energy, I think, is fairly self-explanatory. It's about the action, it's about getting things done, it's about making progress. That's relatively straightforward and relatively easy to see. The intellectual energy is about the analysis, the thinking, and the planning that then leads to that action. Again, a really important piece of work, and you may find different people having more energy in one or other domain. The psychological energy is the energy of courage, of resilience, and feeling safe to do things differently. Now, in order for people to feel psychologically safe, managers and employers play a very big part in that role. They need to make it safe for people to be able to express those views. Remember back to when I was talking about policy and diverse, needing diverse perspectives. If you don't make it safe, you will not get those diverse perspectives coming out at the right time rather than afterwards. And then there is the spiritual energy. And in a way that links back to that intrinsic motivation that I was talking about. It's that sense of commitment, that sense of shared values, that sense of trying to achieve a higher purpose. That is a really important energy that enables that change to happen. And of course, social energy is about that engagement with each other. This is not sitting in a room to do it on your own. It's actually doing it together with other people and engaging with other people. So that's about the need for energy in order to enable that change. The third principle is about the need for both commitment and compliance. So you need compliance on the one hand in order for things to happen in a systematic way, in order to make sure that minimum standards are met and so on, and to enable accountability. But that has got to be balanced with a commitment that brings that energy, that drives that energy, that in a sense, a commitment that builds on that intrinsic motivation that many of us have. So it's really important that those two things are important. And in some ways, commitment is often stronger because that last line that I've got there, you know, on the one hand, under compliance, it may be, if I don't deliver this, I'll fail to meet my performance objectives. My boss is going to be cross with me. But on the other hand, if the commitment is, if I don't deliver this, I let down my colleagues, I let down my group, I let down what we're trying to do. And that can be even more powerful than the accountability one. So those are three very important principles that helps us to drive the change. But the next bit I want to talk about is leadership, because actually, without getting the leadership piece right, my personal belief is none of the rest would work. So the leadership is really important. And system leadership is where you have a collaborative leadership of people in different places, different levels in the system that are coming together to make that change, that are working together to make that change. And how the senior leaders behave is really important because it sets the tone for everything else. So leaders need to be person-centered, not just in terms of the people you're serving, but the people you are serving with. So being really person-centered is really critically important. Engaging people at the front line, and I don't just mean clinically front line, I mean in every sense, people who are really delivering that service to the people that we're serving. There needs to be a relentless focus, keeping an eye on that vision, on that shared purpose, on that strategy. And how do we get there? But also adjusting it as we need to, because with that comes transparency. Transparency in looking at the results, but actually also at the progress and at things that don't go right. And nothing we do is free from defects. No matter how carefully we plan it, no matter how proud we are of it, there will always be defects. And I often use a phrase, you know, let's just hear about it, warts and all. So hear about everything that went wrong as well as everything that went well, because that's the only way we're going to learn. And leaders need to actually interact across boundaries, because if you don't do that, then you're working in silos, and that's a really good way for getting things wrong. So the Institute for Health Improvement, my guess is it came out in 2013. So my guess is that many of you will have seen this before. It's actually a very good paper that talks about a high impact leadership framework. So again, it repeats a little bit of what I've just said. It needs to be driven by the persons and the community that we are serving and that we serve with. We need to create that vision and build the will, build the willingness to do it. We need to develop the capability, because so often people are put in positions of leadership, whether it's senior or middle leadership, and actually aren't given the skills and the capability to develop it. We need to be able to deliver results. It needs to be shaped by the culture, and it needs to shape the culture in which we're in, and it needs to engage across boundaries. Now, I couldn't possibly do a talk at this time without pausing for a minute and thinking about COVID-19 and its impact on policy and practice, as we are all still trying to deal with the pandemic. So I'm just going to briefly tell you a little bit about what we're doing. In England, apart from my national end-of-life care program, we have something called the National Incidence Response Board, which coordinates the response across the country. And within that National Incidence Response Board, there are a number of cells which are focusing on different aspects of healthcare and different aspects of things like supplies and testing and safe hospital discharge and community care and so on. And within that system, there is actually an end-of-life cell. So that was quite important, that actually was recognized that we needed a focus on end-of-life. And I lead that cell at the moment. So our leadership response has been, first of all, to set our objectives. And we had 4 objectives for this wave. In wave 1, we only had 2 objectives. But in this wave, we now have 4 objectives, which is that actually it's really important that we don't stop delivering palliative and end-of-life care, both to existing patients and new patients, and that we encourage them to come forward. Then we needed another objective was getting the system ready to scale up and intensify our efforts. Excuse me. We needed to be ready to provide targeted support for areas that are under greatest pressure. So in somewhere like England, there are, in the last few weeks, we had the northern part of the country under greatest pressure. And now the middle of the country is the one that's under greatest pressure. and gradually the pressure is growing in the south of the country. And so us being able to provide targeted support for our colleagues in those areas is really important. So what do I mean by targeted support? It can be as simple as morale. It can be as simple as having regular calls with my colleagues and just checking in on them and sharing good practice and sharing information and resources. And then we need to think about how do we recover as a country? How do we recover as a healthcare system? And in that recovery, we need to make sure that we maintain the focus on high quality personalized care so it doesn't become a casualty of us being so busy and so frantic and so worried that we don't think about the person in the center. So those are our objectives that we're working on. And we've organized our work into 5 work streams. Again, communication is so critically important. So during the first wave of the pandemic, I had weekly calls with my clinical leaders from across the country. I had weekly calls with our voluntary sector partners, as well as the calls with various other work streams that were not about end-of-life care, but that had an impact. So things like medicine supply, testing, etc. But now in wave 2, we're doing these in a fortnightly way because that feels like the right level of response. But it is a constant communication back and forth between us all. It's not about me telling people what they should be doing. It's me hearing what the problems are and us working a solution out together. We've developed some guidance, some national guidance around managing symptom management during COVID, but also around how the system responds during COVID. Certainly in England, palliative and end-of-life care is very much seen as part of the front line for the COVID response, both in hospital and in the community and in hospices. In the second wave, we have not produced any more guidance because there is no need. We have just checked our guidance to make sure they're up to date and continue to make them available. A third level of work stream is looking at supplies like PPE and medicine supply and making sure that we've got enough of what we need. And our medicines cell colleagues actually have a work stream that is specifically looking at end-of-life medicines and making sure that we've got enough of what we need as the priority medicines. We then have another work stream that looks specifically around issues that are specific to hospices, issues that are specific to care homes, and working with our partners in those areas. And then the last area is about how we work as a team internally, because I have a relatively small team. We have to be on standby for any queries that come into our single point of contact. And there's a whole load of governance work that we have to do internally. And also recognizing that my team is getting tired. They've been flat out since February. They've been working really hard, really long hours, including weekends, and actually they're getting very tired, even if they're not actually at the front line with patients. So what's the impact on practice? Well, there's been a fast and sustained response, and I think palliative care has shown that it is able to do that and to move in very quickly. So I think it's just to remember that actually we're all tired and we all need to be kind and look after each other. And that is such an important message to keep going. And this is particularly pertinent to me because over the last few months, apart from the national work, because I'm clinical lead for my own department, it also has meant a day-to-day care of my colleagues working in my department and delivering the care directly to patients and making sure they are both safe and also both safe physically, but also their physical and mental well-being. So I've nearly finished. I was just going to finish with this last slide, which is really, this is away from COVID again, not necessarily just about COVID, but it's actually some personal take-home messages about how we go, the leadership that enables us to go from transforming policy to practice. I think we need to recognize that relationship building is ongoing. It never stops and it can never stop. But actually, if you build good relationships in the first place, you invest in it and you maintain that foundation, that carries you a very long way. I know that during the COVID response in the last few months that I have not been able to pay as much attention or give as much time or respond as quickly to many of my colleagues and many of our system partners. But because we do have the very strong relationship, it does give me a little bit of slack, and we actually trust each other to be able to manage during this period. when you're building policy, but also when you're building practice, recognizing that there are different agendas, but that is legitimate. They are just different. And people are there to, so for example, my colleagues who work in charities are there to lobby for funds, to lobby for things being different. That is what they're meant to do. And that's absolutely fine. So they are legitimate. It doesn't mean it's necessarily my agenda, but it is okay. And it is important to listen and accept it. And that there are differences in the way we use language and culture. And we know that in healthcare, there are differences in language and culture between doctors and nurses and social workers and psychologists. That is a difference, but we have to accept, recognize, and celebrate those differences, and to value the different voices, including those that don't quite fit with what we're thinking, that don't feel very comfortable because they have a different view, but it's actually really helpful to have that. We need to stay authentic, but actually connect with that wider picture. So it doesn't mean just listening to all those agendas, listening to those different voices, doesn't mean we sway with everything. We do need to keep in mind, remember back to my policy slide where I talk about it being conscience driven, about doing what's right. It's really important to stay authentic to that. But how we do the right thing, of course, may be different. And there may be different ways of doing it. And I think my final message is that we need to hang on to that sense of curiosity, both as individuals and at system level, to that ability to keep examining, to keep looking, to keep asking questions, to have that intellectual curiosity about why did something work? Why did it not work? What was it that made it work well? What was it that wasn't right about it? What is it that we need to change? And so it's staying curious is probably the thing that enables all of those things that I said to be most effective, because it stops us being complacent. Thank you for that.